Thank you very much, Mr. Chairman. These are my disclosures. So OAB and BPH symptoms are frequently reported together. The limited data are available on the efficacy and safety of OAB medications for treating patients with a combination of lower urinary tract symptoms, both storage and voiding. The PLUS study is a 12-week, phase 4 randomized double-blind multi-center trial conducted in 80 sites across North America and Europe. Mirabegron versus placebo for treating OAB symptoms in men receiving tamsulosin for LUTS due to underlying BPH. So it was a comparison, double-blind randomized trial of mirabegron plus placebo versus tamsulosin plus mirabegron. The objective of, it's tamsulosin plus placebo or tamsulosin plus mirabegron. The objective of this presentation is to describe the safety and tolerability findings from the study. The study is being reported and was presented elsewhere. Looking at treatment emergent adverse events, all of them, and also of special interest, and those include changes in PVR volume and Qmax, and home and office-based vital signs, and 12-lead ECGs. This is the study design. Men 40 or more who had been receiving tamsulosin for at least 2 months for LUTS due to BPH in the opinion of the investigator. There was a run-in period of tamsulosin once daily, and they were randomized with a 3-day electronic diary, and they had to have 8 or more micturitions per day, 2 or more urgency episodes of concern, and it was graded, and a PSA less than 10. They were randomized to tamsulosin plus placebo or tamsulosin plus 25 milligrams of mirabegron for 4 weeks, and it was dose escalated to 50 milligrams. That was done because those are the requirements in North America regarding dosing of mirabegron. The PLUS study met its primary efficacy endpoint, which is change from baseline to end of treatment in mean number of micturitions per day, and it was superior to tamsulosin in the number of micturitions per day. It was statistically superior. Both treatments were well tolerated, and this look at the data includes a detailed analysis of the safety. There were a total of 706 men. The mean age was 65, plus or minus 8.9 years. More than 56% of them were 65 or over in the group, and 92% were white, as one sees in clinical trials. The most common comorbidity was hypertension, which in the placebo group was 59%. In the treatment group, tamsulosin plus mirabegron was 55%. That is, patients going into the study. The overall number of treatment emergent adverse events, it was higher. It was 31.4% in the placebo group versus 26% in the treatment group. Drug-related adverse events was a little higher, 12% in the treatment group versus 6% in the placebo group. Treatment events, emergent adverse events leading to study discontinuation was a little bit higher, 2% in the treatment versus 1% in the placebo group. Most of the TEAEs were mild in 61%, or moderate in 33% in patients in the study. The most common reported treatment emergent adverse events was hypertension. There were 3% in the placebo group and 1.7% in the treatment group. That's new onset hypertension, so a very low rate. Headache, about 2%. 2.3% in the placebo versus 1.7% in the treatment. Nasopharyngitis, which you expect with tamsulosin, as you know, occasionally. So it's about 2%, 1.7% in the placebo and 2% in the treatment group. Urinary retention was the only treatment emergent adverse event of special interest reported by 1 or more % in all the groups. There were 2 tamsulosin plus mirabegron required catheterization. Neither event led to study discontinuation. One catheterization was actually secondary to an operation that the patient had had following the treatment end. No cases of BPO requiring surgery was reported. Looking at the specific vital signs, QTc prolongation was not significantly different among between the groups, and it was not of concern. Pulse rates, similarly, there were no signals, and both systolic and diastolic blood pressure was not appreciably elevated across the groups. PVR volume increased by about 15 cc's average in the treatment group and about 3 cc's in the placebo group. Qmax likewise deteriorated by under 2 cc's per second in the treatment versus almost nothing in the placebo group. So overall, mirabegron add-on treatment was well tolerated. Treatment-emergent adverse events were consistent with the known safety profile for mirabegron. No clinically meaningful changes from baseline in vital signs were measured, and no clinically relevant changes in PVR volume and Qmax were seen as well. So there are no unexpected safety concerns in this study, which involved the addition of mirabegron to tamsulosin. The authors would like to thank the PLUS study investigators and all patients who took part. The study was funded by Astellas. Medical writing support was provided by Michael Parsons and Elevate Scientific Solutions and funded by Astellas. Thank you very much.
Thank you very much. And any questions? Paul.
Abrams, Bristol. So I'm interested in this being tamsulosin for underlying BPH. We don't usually treat histology, do we? BPH is a term for histology. That's all it is. And it's not clear from this presentation whether any of these patients actually had benign prostatic obstruction, which the AUA guidelines say is the aim of treatment in these men. They specifically say the aim of treatment is not to BPH. That's in the AUA guidelines, written by Kevin McVary, along with other very notable colleagues. So this is a confusing paper. Do you have any evidence that these men had BPH, because they presumably didn't have biopsies? Do you have any evidence that they had BPO?
Actually, that question is being answered currently on the basis of reviews from the PLUS study. But I must remind you, Paul, that this paper is just on the treatment-emergent adverse events. It's not on the study design nor the rationale behind the study. And yes, you're correct. And the committee has agonized and debated this whole term. And actually, the bottom line was essentially, which is not related to my presentation today, is that it's the concept of men with lower urinary tract symptoms who are diagnosed by their urologist to have lower urinary tract symptoms on the basis of their prostate, and they're treated with tamsulosin, and residual or concomitant OAB symptoms that are ongoing can be treated safely and effectively to some degree with mirabegron. So it was just to convey the information about this patient treatment group. And yes, there's a terminology issue, the diagnosis issue. We're grappling with those questions.
Can I say that there are some very important members of ICS here, on the scientific committee, et cetera, et cetera. There are 5 papers in this session which refer to BPH. I said it was the AUA accepted nomenclature. It's been the ICS accepted nomenclature since 2002. Isn't it about time that presenters were asked to standardize their nomenclature and use meaningful terms? BPH is utterly misleading. BPH has exactly the same prevalence of age. So if you're over 80, you have an 80% chance of having BPH. Of course, you don't have an 80% chance of having prostatic obstruction, much, much less. So this term is meaningless. And I would say that your commercial sponsorship may well be the reason. Now, I don't attribute blame to Astellas. Their problem is that the FDA, which is a very old thinking organization, still use the term BPH and recognize drug use for BPH. And this is wrong. And it's about time colleagues like you, who are very senior, say to the FDA, no, this is wrong. The nomenclature by all the scientific societies say you use the term BPO if you're aiming to alleviate obstruction. You use BPH if you've got histology. All the scientific studies say that. What do you think? Do you have a responsibility to challenge the FDA in this?
If I were an American citizen, I'd feel that responsibility.
Okay, well, is Kaplan here?
I mean, it's a really meaningful discussion, but I think we need to head on to the next, otherwise the other two presenters will have no time for their presentation.
Thank you.
So thank you.